Good morning, everyone, and welcome to Cardiology Grand Rounds. Today, we're pleased to introduce really one of our own, Dr. Norm Wong, who has been a longstanding presence through my career and at the University of Calgary. He is an endocrinologist and a professor of molecular biology and cellular biology, and has had a career-long interest in endocrine regulation of lipids and cholesterol control. Today, he has agreed to come forward and speak to us about the recent developments in the area of lipid control and obesity. He's going to report on some of the trials that were presented at the ESC. So Norm, welcome and thank you for coming out.
Thanks for the introduction. Yeah, I'm an old guy here. I've been here around. I think I've been in this building probably way before you guys were born. I think it was 1974, 74, 73 when the building was, we only had this part. Yeah, almost, yeah. Well, thanks for the introduction, Andrew. It's a pleasure to be here this morning. And like Andrew said, I press the button here and there we go. And I'm going to try to talk about things that I learned at the latest European Society of Cardiology meeting. And it took place in Amsterdam. And the way I pulled it all together was how could I make it so everybody could understand it was how to get rid of unwanted fats and edema. And hopefully that'll sort of, pull the themes together and weave it together so that cardiologists and endocrinologists can understand it and hopefully, go forth and work together. So with that in mind, the scenes below are where the conference center is. That's the metro stop, and here are some of the slides. And I'll tell you that the theme really evolved around metabolic things. And the topics that I want to cover with you are some of the new therapies that are being developed in the area of GLP-1 receptor agonists, SGLT2 inhibitors, the siRNA inclisiran, the olpasiran siRNA, and then a real new one that's called VERVE-201, and that's the first CRISPR gene editing therapy that I think will come out for treatment of lipid disorders. And then we're going to look at some of the diseases that are targeted by these new therapies. And then if there's time, I'm not going to extend my time. I'm going to try to finish in about 40, 45 minutes. And if there's time, I'm going to tell you about the details of the new ESC guidelines for the treatment of diabetes and cardiovascular disease. This slide really summarizes what was the theme of the conference. And I'm going to go to the EASD meeting this coming weekend. And I think that the theme will be the same. It's how we battle obesity, okay? And to the right is sort of my diagram of how it links all together is that diabetes begets type 2 diabetes, and type 2 diabetes is really the harbinger of lots of risk factors for development of CKD, ASCVD, cardiovascular, heart failure, et cetera. All those things are linked together. And here on the bottom right, you're going to see this diagram pop up again as we go through. And the green arrow will tell you where we are in the roadmap. And like I said, I'm going to try to finish in about 35 minutes or so. One thing, if you walk away from this lecture, don't remembering anything, remember one thing. GLP-1 receptor agonists, SGLT2 inhibitors, LDL lowering drugs, and finerenone are all endocrine drugs, okay? And although there's some of you in the audience think that SGLT2 inhibitors are cardiovascular drugs that just happen to have glucose lowering, that's not actually true. We're in this field, and we've been in this field for about 6 to 7 years now. And who said that? the endocrinologists were the pioneers, okay? And they were the ones who learned how to use these drugs. And now we're getting pushed out, okay? So the cardiologists are using the GLP-1 receptor agonists now, and especially the SGLT2 inhibitors, which you're very familiar with. Remember, there are no GLP-1s or SGLT2 transporters in the heart. So these are all what we call indirect effects of these medications and how they impact the cardiovascular system. Okay, so who's this? Who's this? Really? Oh, she knows. I was going to give you a hint. This is her famous sister. This is Kim Kardashian, okay? So on the bottom left there, you see what the transformation that she undertook in about 7 years. Mind you, this is celebrities, Hollywood, and whatever you call it. There was some plastic surgery between here and there, but the belief is that her weight loss arose quite substantially from the use of the drug that I will talk about, which is semaglutide and a GLP-1 receptor activity. This guy's not ashamed. This guy actually openly admits that he used semaglutide in order to lose something like 30, 40 pounds of weight. This person is not so famous, but she's important to me because she's the mom of my granddaughter's or my granddaughter's friend. And I've known her for years. And she tells me that back about 6, 7 years ago, she had some sort of gynecologic surgery, had some drugs associated with it. And soon after the surgery, she gained something like 50, 60 pounds or something like that. And she says, I don't look anything like I used to look. So I said, well, why don't you think about these new drugs that we have now called GLP-1 receptor agonists, and they're used specifically for weight loss. And here's her transition from fall to about a month and a half ago. She lost 68 pounds. And the graph to the left here shows the progression of her weight loss, and this is linear. When she gave herself the injections of once a week semaglutide, she lost 68 pounds, and she felt much better. And you can see on the bottom there that she had quite a bit of cardiovascular risks, such as dyslipidemia, dysglycemia, and hypertension before she started the drug. And after she started using it, she lost 68 pounds. Okay, so to me, that's quite important. She turned out quite happy. She's buying a new wardrobe now, so, and her daughter is following in her footsteps, so she's quite happy with her weight loss. So how do these things work? GLP-1s are incretins, okay? They are being released by your stomach right now. You've had breakfast. And what it does is it stimulates the pancreas to release insulin, but at the same time blocks the counter-regulatory hormone, glucagon. And the two together then leads rise to a lowering of the glucose. But in addition to controlling diabetes and dysglycemia associated with the use of GLP-1, there are two other characteristics that we really like in this class of drugs, is that it suppresses the transition of food through the stomach or lowers the motility of the GI tract. But in addition, it suppresses brain activity. So we now have learned so much about these drugs that we are able to create different variants and epitopes of these that are being tested in animals to a point where they can trigger the animal to eat rice or not to eat rice with those drugs. So things are coming. So these drugs have been proven substantially over the years to be useful in the treatment of diabetes. And here we have the effect of GLP-1 receptor agonists on hemoglobin A1C. Here it is on body weight, and this is semaglutide here. Dulaglutide is shown to the right here. And again, there's effects on blood pressure, but there is an increase in the heart rate, which is something that we don't like, but we have to tolerate it with the use of these medications. So GLP-1 receptor agonist has characteristics that we find to be useful in the treatment of diabetes and also in weight. Here is the sort of the usefulness of these medications in cardiovascular disease. There are two studies before you called Leader 6 using liraglutide and Sustain 6 using semaglutide. And both of these papers were published about 7 years ago now, showing that they had an impact on MACE. Liraglutide, about 13% impact, mainly driven by cardiovascular death. Sustain 6, which is semaglutide, is shown here with an impact of 26% reduction in MACE events, mainly driven by non-fatal stroke. So both of these agents, plus the liraglutide and now with albiglutide, all of these GLP-1 receptor agonists have some sort of feature in creating benefits in reducing MACE events. So these have been proven to save lives, okay? Here are the medications that we're talking about. Here on the left is the semaglutide. The yellow shows that it is a peptide. It is a long peptide, so therefore these medications are injected and they are configured or developed in such a way to have a long chain fatty acid that binds the albumin to give it sustained release. So once a week injection is all you need. But they've also now have a oral form of semaglutide that is out. It's quite expensive for the medication. So we use mainly the injectable forms in the clinics that I work in. Okay, so this is what we call a GLP-1 receptor agonist. On the right here is a new molecule called tirzepatide. Tirzepatide is a dual agonist. It affects both GLP-1 receptors and GIP. And this medication is a little bit longer, has long amino acid chain here, followed by a fatty acid. And again, it's once a week injection of this medication. And this medication has been approved, but neither one, although semaglutide is approved, tirzepatide is also approved, we don't have any because the American public bought it all up. We've had it approved for over almost 2 years now with semaglutide. We still do not have the 2.4 milligram dosing. We have 1 milligram, meaning that in the public, we can use the 1 milligram for the treatment of diabetes, but we don't have the 2.4. Okay? So my patient actually takes the 1 milligram, but just clicks it more times in order to get the amount needed. Tirzepatide, the difference between, like I say, is a dual agonist versus a mono GLP-1 receptor agonist has weight loss in the range of about 20 some odd percent. This one is about 14, 15%. And soon, listen to this, there's going to be triple agonists and they will cause you to lose 30% of your weight loss. And that's equivalent to gastric surgery or to surgical treatments for weight loss. So these are things that are all coming. So just to provide you a brief review of where the data comes from for semaglutide, there's a program that's abbreviated STEP, or the acronym for the STEP is semaglutide treatment effects in people with obesity. Here's step 1, 2, and 3, which are in chronologic order. The 1 is in obese patients without diabetes. 2 is in patients who are obese with diabetes. And 3 is in morbidly obese individuals. And this is generally the consort diagram or the schematic showing how the patients were treated with a progressive stepwise increase because it takes time to tolerate the medication. One of the potential side effects of this medication that many of my patients get is they get full, they have nausea, they don't have an appetite. So it takes a little while for them to get accustomed, but I would say 1/3 to a half of the patient will get these sort of symptoms, but within about 2-3 months, it's all gone. They can tolerate the medication. Very few people would stop it because of these side effects, or they call it tolerance. Okay, so here are the summaries of the trials. Step 1, 12.4%. Diabetes is always a little bit tougher, so it's only 6% weight loss. And then those who are morbidly obese have about a 10% weight loss over the clinical trials. And I've shown you the benefits of the GLP-1 receptor agonists semaglutide in reducing hemoglobin A1C. And to us in the area of diabetes, 1.5% is quite a lot of reduction in hemoglobin A1C. And the weight loss, like I said, is about 6% reduction. So ESC took place about a month ago. And one of the main hot line items that we were exposed to or treated to was the use of semaglutide in patients with obesity and HFpEF, okay? I see Dr. Howlett sitting in the audience, and I think he agrees with me that diuretics are basically useless in HFpEF, right, Dr. Howlett? And SGLT2 inhibitors are not just simply fancy diuretics. I knew he was gonna do that. But anyway, so the HFpEF was the focus of the trial, because I'm not a cardiologist, but I hear from you guys that it's a pretty tough one to treat because there's not many medications that can treat it. So if we focus our attention on obese individuals with HFpEF, which is probably one of the sort of characteristics of HFpEF, is that it's an external thing to the heart that gives rise to it. And in this particular case, it could be, like obesity. In my field, it's diabetes that gives rise to it. You're familiar with this sort of diagram in which they ramp up the dose to 2.4 milligrams in a day, or in a week, sorry, and then assess them by using the quality of life, the Kansas City questionnaire, okay, developed by the fellow who led the study, Kazi Boro. And then there is a dual primary endpoint. There was how do you feel after the weight loss, and how much weight did you lose? He was going to hit this. This was a known, okay, because these are medications that we've used for 7-8 years now, and we knew they were going to lose weight. We didn't know about whether they would feel better in regards to their heart failure. They also had a 6-minute walking distance after a year. And you can see that there's quite an increase of about 20 meters or so after the treatment with the drug. And then now what's popular is what they call win ratio, looking at secondary endpoints, including CRP levels in that secondary endpoint. And you can see that it wins in all the cases, okay? So what were the conclusions from this trial that lasted about a year or so, involving patients who were obese? Their BMI were greater than 30. They all had heart failure to some sort, New York classification 2 to 4. Okay, semaglutide 2.4 milligrams weekly improved their heart failure symptoms according to the questionnaire. Their 6-minute walking distance was better. They had reduced inflammation. Of course, they were going to lose weight because the medication is designed for that. And what we're saying for Canadian use is that, yeah, we need a bit more information, but I think that this will make changes in how we practice. And one of the reviewers of the paper came up with this, is that when you ask your overweight patients if they feel better after losing weight, what do you expect is going to be the answer? And the answer was, of course, the guy was going to, hit all the endpoints. And it was called, there are 2 publications that you should go read. It's in the New England Journal and in Nature Medicine. The Nature Medicine dealt with the anti-inflammatory effects of this drug, and then the New England Journal dealt with sort of the heart failure. Okay, what's coming? Who's going to the AHA this year in November? Nobody? Nobody's going to go. Okay. So at AHA, you're going to see the information rising from the SELECT trial. Well, what is a SELECT trial? So the STEP HEF trial dealt with sort of, did you feel better? Did you lose some weight? Can you walk a little bit more? These are pretty soft, not as hard as you like. This is a trial in which they give patients with obesity, cardiovascular disease, established cardiovascular disease, and they're going to do a body count, okay? So this is a MACE event trial, very hard point, non-fatal stroke, non-fatal MI, and CVD death, okay? And they're going to do it in these patients, and guess what? Top line data, 20% reduction in MACE. So I think this is going to become important for you guys sitting in the audience who are dealing with these patients who have obesity and they have established cardiovascular disease. 2.4 milligrams of semaglutide once a week is going to 20%. Okay, so hopefully we've done with the first item that I'm talking about, that GLP-1 receptor agonist reduces weight, reduces glucose, improves HFpEF, and saves lives. Okay, and now we're going to go on to the second one, is talk very briefly about SGLT2s. And I'm sure you've heard the expression, apple a day keeps a doctor away. It probably works, you know, just because these the molecules that these SGLT2 inhibitors are based on came from an apple tree. It was the bark of the apple tree. They were looking for antipyretics and they didn't find antipyretic, but they found fluorescein. And this one, you use the various isoforms of this molecule, is an inhibitor for the sodium glucose luminal transporter 2, and mainly the one that sits in the proximal tubule, which is the workhorse. This takes care of 90% of the glucose, and its main role is to reabsorb whatever glucose you filtrate into the effluent of the nephrons, and they try to get back every little bit of glucose that you can get or you've eaten. And then along with it comes sodium. But if you block it with an SGLT2 inhibitor, then you lose the glucose as well as the sodium. And within the name gives you the benefits of both losing calories and sodium. And that's good things for diabetes, because you see here in the EMPA-REG trial, which was done by Bernie Zinman, who's a Canadian in Toronto. First sets of data using empagliflozin shows that hemoglobin A1C drops by about 0.8. Weight reduction is modest. It's only about a couple to 3 kilograms or so, but there's reduction in blood pressure, and that sort of summarizes what it does. You lose calories and you lose sodium, so you lose blood pressure or decreased blood pressure, glucose, and weight. And again, MACE trials that were published 6-7 years ago showed the benefits, and across the board you'll see that there's more than one molecule that gives rise to these benefits, showing that MACE reduction of about 14% by either empagliflozin or canagliflozin benefits those patients in saving lives. The problem with the SGLT2 inhibitors currently in Alberta is shown in this publication that was written by Sonia and James Kim, who are part of our faculty and clinical associates, is that even though we know the guidelines, we know what characteristics to pick out our patients in, the bottom line of that paper, which was just published last year, is less than 25% of those patients who qualify for the drug are actually put on the medication itself. We don't know why. We say it's cost. We don't actually know why we're not using it as much, but we're not. Okay, so here's a cardiologist. This is from the ESC. It was a poster presentation, and it shows that the use of SGLT2 inhibitors in the cardiology practice has really risen substantially since the publication of the DAPA-HF, which Jonathan was part of the authors in, the Emperor Reserve or Reduced trial, and the Emperor Preserved trial, which is HFrEF and HFpEF. And then the liver, you can see that there's quite a substantial rise in the use of the SGLT2 inhibitors in the cardiovascular population. So the use of SGLT2s is rising, especially amongst the cardiologists. Okay, so let's go to the last part of the talk, to dealing more with things that I'm comfortable with, and our Dean Todd is comfortable with, in dealing with lipids and LDL, and how we approach these sort of residual risk factors in our patients with cardiovascular disease. Shown here are the 6 sort of factors that we look at in terms of what things we can do as endocrinologists and cardiologists to reduce the risk of events in our patients with cardiovascular disease. And everybody knows about LDL. Okay, the CANTOS trial told us about the inflammatory process that goes on. I don't know much about lipid or platelets and thrombosis, but most of you know much more than me. I know about the triglycerides with a EPA, okay? And then we're going to talk a little bit about LP little a in this discussion because probably next year, you are going to be introduced to siRNA or other drugs associated with the reduction of LP little a. This is a very good article that was just published about a few weeks ago. And it summarizes the diagram of the lipid sort of crossroads at which we as endocrinologists and you as cardiologists know where to interfere with to lower LDL and lower triglycerides. And I've sort of highlighted in the yellow here, these are the medications that we already know about. We have in our cabinet to use for our patients, like the bile acid sequestrants, the statins, the PCSK9 antibody, the ezetimibe, we're all very familiar with. In the red, however, that you can see here, these are the new ones that are coming out. And many of these were discussed in the ESC meeting. You heard about the CLEAR trials, which is pimpadolic acid, that inhibits the ATP citric lyase enzyme, which has shown to be positive, but it's not generally going to be that impactful, I think, because the MACE reductions were a little bit lower than expected. We're going to talk about inclisiran. We're going to talk about ANGPLT3 as another target. And then we're going to talk about LP little a, which is not shown on this slide, but that's important to think about and learn about as we learn more about the medications. This is an old slide that many of you have committed to memory, I hope. And this summarizes the impact of PCSK9 protein and its role in LDL metabolism. Shown to the left here is the typical normal sort of processing pathway in which LDL particles come in contact with the receptor, and then they get internalized together as a complex, and some of it gets degraded, but then they get recycled. And if you remember, the LDL receptor can actually recycle about 100 to 150 times. But when you get old like me, it becomes senile, you get rid of these things. And so that's where PCSK9 comes in. It acts as a filter or a tag to identify old people or old receptors, and you do away with them by metabolizing them and getting rid of them, okay? So what happens is that if you take PCSK9 out of the picture by using an antibody, as shown in the third panel here, you sequester the PCSK9, it no longer can work. So it can't identify the old receptors or the ones that are due for degradation and allows them to recycle. So instead of 100 times or 150 times, the receptor recycles 300 times or 200 times. And that's why you see the picture here. In the presence of something that blocks PCSK9, you get much more LDL receptor on the surface, and therefore you get lower LDL. Now, the new thing is, rather than an antibody now, we have a medication that's available called inclisiran. Inclisiran is a novel molecule that involves an siRNA, a guide strand, and also a passenger strand, and then connected to a moiety that targets it for a liver. This is GalNAc. So GalNAc is a sugar moiety that only targets the liver because there's only GalNAc receptors in the liver. So when you tag this onto this sort of double-stranded RNA, it really targets it for the liver, okay? And the whole purpose of this targeting is to get it to the liver, and then the active part of the molecule is the guide strand, and that's the strand that does its work to reduce the messenger RNA for PCSK9. So that's why the name siRNA. It's a silencing RNA to get rid of the messenger RNA that encodes the PCSK9 protein. You've heard about the COVID vaccine? Well, it's a little bit like that. When you got your COVID vaccine, you actually got a messenger RNA that encoded the spike protein, okay? So this is sort of like the anti-messenger RNA that's going to target the PCSK9 messenger RNA. So there are two types of RNA sort of therapies out there. The one to the left, I just want you to look at and then forget about it because we're not going to talk about it. It's short strands of RNA. Okay. So what I want you to look at is the right side. And this is what the inclisiran is. It's an siRNA that's going to make a long-lasting silencing complex once it's loaded. And then it will go and seek out all the messenger RNAs for PCSK9 and then destroy them. And so you don't get PCSK9 at the end, okay? So that's how it works. Here's the inclisiran coming in. It creates that complex, which has a half-life of almost 6 months, okay? And it will do away with the messenger RNA such that you get, at the outcome here, no PCSK9 protein to destroy the receptor for the LDL receptor. Orion 8 was the information that we got exposed to at the meeting in Amsterdam. And it was to look at safety and efficacy of inclisiran in all of the trials that had been done previous to it. So basically, when they had 9, 10, 11, looking at primary endpoints of LDL reduction and safety, etc., they took all these patients, lumped them into here, and then asked the question, what happens with the LDL levels after they gave them their injections of the inclisiran? So inclisiran is an injectable medication. You load the patient up on day 0. 3 months later, you give them their next dose of the inclisiran, and then you don't need any more for every 6 months afterwards, okay? And for 3 years or 4 years after these trials that were shown here, Orion 9, 10, and 11, these were the patients that comprise Orion 8. And the question was to ask, what happens to the LDL levels? Here you see that constantly across the board, about 70 to 80% reduction in LDL levels, given the regime of the inclisiran that I showed you previously. So your patients no longer have to remember to take statins every day. They give them an injection. It's done in offices or at the pharmacy. And once you do that, you get about a 70 to 80% reduction. And here's targeting for the threshold levels of less than 1.8 or less than 2.6. You can see that it was very good in reducing the LDL levels. And the side effects were not attributed mostly, except for very few cases, to the study drugs. So it's safe in the use of these medications. And the conclusions were that inclisiran administered twice yearly after the loading dose has a sustained and potent effect on LDL-C lowering and can bring most of the high-risk patients below the guidelines recommended. And we are now being exposed to inclisiran because it's available on the shelves now. And we're gaining experience in how to use this medication to lower LDL levels in our patients with ischemic heart disease. Okay, couple of quick posters. I found this one to be interesting, and it used PCSK9 antibody evolocumab. And in this poster, it asked the question, what does targeting PCSK9 protein do with an antibody? Does it lead to any effect on inflammation? And this is just the background and the method slide, and it used a radio-labeled PET scan to look at what is the area of inflammation in the presence of placebo or in the presence of the antibody. And you can see very clearly Here is a picture of a typical patient. The blue shows the placebo. The red shows the treatment with the evolocumab. You can see that the area damage from the infarction is here and here for the antibody. And after 30 days, you can see there's a clear reduction in the area of inflammation, telling us that antibody treatment within a few days after the MI using the antibody could lead to reduce inflammation in the area of the infarct. And when you do many patients, you can see that there's statistical reduction in the area of the infarction. And it summarizes here that with antibody usage, evolocumab, 24 hours improves resolution of myocardial infarction. Okay. The last poster, and I think I'm gonna end in about 5 minutes. This is Star Wars stuff. Okay. Who has heard about CRISPR? CRISPR-Cas9? Yeah. Okay, this is one of examples of a new therapy that's coming using CRISPR-Cas9. CRISPR is the innate immunity that a bacteria uses to stop it getting viral infections, okay? So you may or may not know it, but bacteria are pretty smart. They figured out how not to die from phage infections. And we sort of stumbled upon this, not me, but the scientists that got the Nobel Prize about 3 years ago, discovered this, and it's a gene editing. So what the bacteria uses it for is that if it gets infected by a virus, it takes that DNA from the virus and passes it on to the next generation. So it remembers what that virus was and so it won't get killed by the same virus, right? Well, that sort of process involved CRISPR-Cas9, okay? So really it's identification. These are sort of what we call inverted repeat sequences that are short things, and that's how the bacteria uses it to recognize. And the enzyme, which is Cas9, recognizes those sequences, and its job is to splice in whatever things that the bacteria wants it to do, so that it can save itself from the virus. Well, this is now technology change our DNA. This is only on somatic, so it's not on embryonic, so we don't pass it from one generation. We're not going to create whatever things that we shouldn't be creating. But what it utilizes is it can change one base pair from a A to a G. That one base pair change is going to introduce a stop codon into ANGPLT3. ANGPLT3 is a protein that leads to the activation of LPL, lipoprotein lipase, and it can lead to more LDL and stuff like that. If you inhibit it, okay, by blocking its production and blocking its activity, because we now have an antibody against ANGPLT3. But this particular therapy involves CRISPR. And what it is exactly what I explained to you just a little while ago. It's nanoparticles, okay, in which they have coated it with GalNAc, so it only goes to the liver. And its purpose for the nanoparticles is to deliver two things. One is the guide RNA to take the sequence to the site of the ANGPLT3 gene and edit that one nucleotide. The second thing that it has in it is a messenger RNA that encodes the Cas9 protein, because we don't have that in our body, okay? So we have to introduce, it's a bacterial protein. So we have to introduce that into the liver. So both of these are then passengers on this nanoparticle that goes directly to the liver. And when it goes to the liver, if you can see sort of where I'm pointing, can you see? Oh, I was pointing at the wrong thing. I'm sorry, guys. Okay, so here's the nanoparticles going to the liver. Here's the guide RNA that introduces that one nucleotide change here, okay? And this is the RNA that attracts the Cas9 protein, okay? So when you put this into the liver, the messenger RNA makes Cas9, which is 160 kilodalton protein. When you put this RNA along with the guide RNA into the person and into the nucleus, it attracts the Cas9 protein, which is shown in purple here, and you get this one edit in change of a A to a G. And that one nucleotide puts in the stop codon. And here's the infection in hepatocytes showing that it works, okay? Here it is in animal showing editing works. And here in the blood shows the reduction in the ANGPLT3, okay? So basically, here's placebo showing variations in the LDL level or in the ANGPLT3 level. Here it is in the ANGPLT3 protein. You're getting somewhat about 90% reduction, okay? So this is still in animals, but early next year, they're gonna start human trials using gene edit, CRISPR-Cas9 as the tech. Okay. So, hey, 2 minutes. Okay, Ocean A, this is the LP little a. I think you as cardiologists know that about 20% of the population carry this defect, and because this defect produces a protein called apo little a with a bracket behind it, not apoA1. Okay, this is a defective protein that attaches to ApoB, and when it attaches to ApoB, the whole particle becomes much more pathogenic than it is with just the LDL particle by itself, causing a whole series of diseases that includes ischemic heart disease, atherosclerosis, strokes, etc. And the mechanism of the new drug you already know is the same one as inclisiran, but the siRNA is targeted against LP little a, goes through creating the RISC complex and then finding messenger RNA and destroying it so that you can get a reduction in LP little a levels. And to make a long story short, dose-dependent reduction in LP little a levels given 10 milligrams at 12 weeks, 75 milligrams at 12 weeks, or 225 after 12 weeks. Nice dose reduction in the LP little a level. And then here is the extension of the Ocean A trial. You get the drug, okay? Either here's placebo, here's placebo, and then here is treatment with 10, there's treatment with 75, or treatment in the yellow with 225. And this effect lasts upwards of almost a year following the last injection of the olpasiran, which is the name for the siRNA against LP little a. Okay, so LP little a reduction with siRNA works. It's robust, okay? It also reduces the ApoB oxidized levels, which I haven't shown you, but given the 75 milligrams or greater than 75, even after a year stopping the drug, you still get a 50% reduction in LP little a. So that's coming out probably next year when it gets approved. Okay, I think I'm going to end it here. I'm not going to go to the last part. And then just the last part is that lots of new ways to lower LP little a and lower LDL, and gene editing is coming. So with that, I'll end, and I'm happy to answer questions.
Okay, we're going to open it up to questions. I'll start with one. Okay, it's a little bit of a philosophical question about these medications. We have, as cardiologists, endocrinologists, been focusing on lifestyle modification, exercise, lose weight, or say a failure to carry. And we now have medications more and more that can cause you to lose weight, that can address risk factors that are addressed by exercise. How are we going to, as physicians, move?
they're additions to lifestyle. So they're not in the total exclusion lifestyle. So we know that lifestyle, the best you can do, the best. Exercise, run a marathon. I don't know, 9%. That's as good as we can do. Okay, we can healthy else. You're talking 9%. Okay? Well, these things, okay, you're talking, you know, when the new ones come, you're talking 30. Tempting to say, well, it's your fault. You didn't do what I told you to do. Well, it's not that. It's some part of it is, but it's not their fault. I mean, it's biology. But we will have this. I would say no, we don't exercise. We don't exclude that. That's good. Healthy. This stuff on top of it. Generation is 12%. 20%. The third generation drugs out.
As a follow-up to that,
Sorry, did you unmute the?
Yeah, we do.
as a follow-up to that, do you have to be an Elon or a Kardashian to be able to afford these?
That's a good question. So they're not cheap. Okay. When I first started working with PCSK9 antibodies, they came out 14,000, right? Who can afford 14,000, right? Drugs, they're not much different. Yeah, they're gonna be cheap. Okay. Right now, semaglutide is covered, meaning it's on the formulary. We can use it for diabetes. So partial is paid for, but I don't think that obesity will be, you know, some insurance policies that do cover it for a moment, but yeah, we're gonna have to deal with that. Not cheap.
When they reach their ideal weight, when they reach their ideal weight, do they have to stay on it?
Yeah, that's very good. So my granddaughter's mom, so I got to her, yeah, you know, you should be on 2 point something. So she gets up to there, she loses the weight, okay, and she doesn't tell me until, are you sure you think? So she backed herself down to about 1 milligram. Okay, so we know that if you stop the medication, there is some rebound. Okay, and after a year or so, even though you're off the medication, you still lose about 5%, or the 5% total is low. But guess what? Yo-yoing is no good. So that's why I learned that ESC said, don't do this. Once you're down, you stay down. Or you're up, you stay up, and you're not going to get problems with your heart. But if you yo-yo,
I'd invite people to put questions on the chat if they'd like, or speak up. So
was there a question?
it doesn't look like there are questions.
Okay.
The questions in the room?
I have another one. So are the rheumatologists and possibly the cancer people with the anti-inflammatory effects going to steal your drugs too?
I haven't seen too many rheumatology people or oncologists at our meetings yet, but I see these guys around, the cardiologists around all the time. Actually, we share in the meetings, like lots of endocrinologists now at the cardiovascular meetings, and it's teamwork, right? Right, Jonathan?
No, I just wonder with the anti-inflammatory
Yeah, but I think they're better in anti-inflammatory drugs like the IL-1 beta, you know, body. I think those are better.
right, but a lot of the problem there is weight loss too, like when you're talking about rheumatology.
Oh yeah, the rheumatologist, they want weight gain, not weight loss, right? In some patients. Yes, Jonathan.
We're waiting for you.
No, don't worry, we're.
Yeah,
Hey, Nasty.
he's biding his time.
The, so you just mentioned STEP, so we're part of STEP DM, which is coming out later, but we weren't part of the first trial. So in that trial, there was about something in the range of 30 or 35% lowering of CRP, right? So is that typical of other weight loss trials? Is that about the same amount of CRP reduction that you would get in say some of the earlier STEP trials, or for other types of weight loss using, the less effective generation of weight loss drugs before semaglutide came out? Do you typically see that type of a CRP change?
So I don't really know the answer to the question. You know that fat or adipocytes and paucity is associated with inflammation, okay? Chronic inflammatory effect on. I'm not sure of how many studies would measure CRP. I have to go back and look at those to see if they really did or did not measure CRP, say back in Sustain 6 or Leader 6 trial. But then going forward, I'm pretty sure that the STEP trials, knowing what they saw here, will start measuring it. I'm pretty sure the terzepatide trials will be met. That's all? You're not going to ask me about diuretics?
Well, sure. How about if I ask the group, like, how many people think diuretics reduce mortality in heart failure? Anybody? How many people think?
Oh,
they don't?
in general heart failure, in general
people
heart
think they
failure.
don't?
No, okay.
Okay, so how many people won't use diuretic for heart failure? Oh, okay, got it. I'll kill you with it. Yeah, sure, right?
So here's what I know as an
Yeah.
endocrinologist, okay? First of all, in HFpEF, there are no randomized clinical trials showing the benefit of diuretics. So all of the data that I have read about from review articles is that there's meta-analysis on old trials, okay? And they say, oh, this looks like there's a benefit. But meta-analysis are totally useless, right? Because they're meant to ask questions rather than confirm data, okay? Now in HFrEF, tell me about HFrEF. Is there diuretic trials in HFrEF?
Small ones. Full diuretic withdrawal trials.
So this is similar to our situation with metformin. My last slide, I'm just gonna show, if I can, to the last slide. Because you guys, okay, here. Okay. Your guidelines have eliminated metformin. So the ESC guidelines for diabetes and cardiovascular disease, you guys jumped over metformin. There's no mention of metformin. The first line trials, the first line drugs, SGLT2 inhibitors, GLP-1 receptor agonists. If you don't get the target, which you don't, glucose, then you start to look at metformin. Really don't use metformin. You know what? I agree with you guys.
So the problem with that is a lot of these initial trials were done in the presence of. So where's the evidence of? We have sufficient evidence. All the early endocrinology are doing well. We can't. That's.
I don't know, but total information on metformin is 300 patients benefited from metformin. Basically, I mean, like diuretics don't have any data. Heart failure, right, Jonathan? It's the same thing.
About holding these drugs for surgery, we often get into problems. The anesthetists aren't very happy with us. We don't hold these drugs. But if you need to put in a pacemaker with someone with a temporary pacemaker, you don't have that time to hold the drugs for a couple of days. What can we be?
No trouble. I mean, GLP-1 receptor agonists are once a week. SGLT2 inhibitors, in fact, we have the guidelines in our guidelines is that if they're sick, we hold SGLT2 inhibitors. Okay, question. Yeah, so I have online a question about in your HFpEF patients with obesity who can afford GLP-1 receptor agonists, would you suggest this agent wait for heart outcomes data? Well, you're probably going to see some of that in the SELECT trial, and the SELECT trial is positive, and that's going to become available probably in a couple of months. So the longest you probably have to wait is a couple of months to have an answer. And it looks like it's going to be positive. There's a 20% reduction in MACE.
Top of the hour. Okay, so thanks very much,
Okay.
Dr. Wong. That was fantastic. Exciting time. I just like to tell everyone next week we're having a change of venue for the live room. We're going to 1405, which is up by the library. So, along live again.